everyone, I'm Dr. Anthony James. I'm the Director of Education here at the beautiful Thai Yoga Center in Brooksville, Florida. Today, I'm going to help you dive deeper behind the pressure in the arm routine or the arm and hand routine into some of the benefits and some of the concepts of why working on the arm in a dedicated fashion is so valuable. I hope this video is really helpful for you. I appreciate your subscribing, your comments, and your likes. See you soon. Bye-bye. If you feel like your arm, your shoulder, elbow, wrist, hand is not right, it affects your whole well-being. It affects your whole body. It affects how you feel altogether. If any of you have ever had chronic shoulder problems or chronic elbow problems or chronic wrist problems, then you know what I'm talking about. It's amazing how much that can really depress you and set you back as far as feeling good and all this kind of thing. Especially when we get down to the hand and wrist, well, actually all three. These joints are vulnerable, especially if you work with your arms and hands. If you're a hands-on therapist, if you're a massage therapist, you're a physical therapist, orthopedic therapist, all of these people have disabilities that center around the most valuable assets that they have to work with, which are their hands and arms. All right, and so, for example, I found in the past that some of my best clients, if you will, to receive this kind of emphasis are actually healers and therapists, and people who practice because of all the manipulation they do, especially when you get into the massage field, because all the technology of currently massage and massage therapy is essentially based on squeezing, basically based on squeezing the hands, which creates a repetitive stress situation because your hands are not actually made for that. The hands are actually made more, if I want to say it this way, for articulation and for communication and expression than they are for hard repetitive work. And when you do simple motions thousands and thousands of times with the arms and hands, well, they deteriorate. That's just how it is. One of the brilliant things, again, for me about yoga therapy, and specifically Thai yoga therapy, is the fact that we use our whole body to work the client's whole body. So I'm never in a situation where I'm overusing my hands. It just doesn't happen. And even if I didn't have any hands, how about that? This is even one of my more favorite things, okay? Even if I was an amputee and I didn't have any hands at all, I could still do probably 90% of all the facilitations that we do in the postural facilitations and so on and so forth. I can do them with my feet. I can do them with my legs. I can do them with my knees. You know, if I don't want to use my hands, I can do sessions easily with a slight modification, and I virtually never actually have to touch the client with my hands. Okay, and so we call that hands-free Thai yoga, okay, or hands-free yoga therapy. And I've been promoting that as an acceptable variation as long as I've been teaching. As long as I've been teaching. We've been introduced to this idea of working without using your hands. Okay? Of course, if you're not overusing your hands and not overusing your arms, well then they should be good to go. They should be good to go indefinitely. And we have really good role models. We have lots of old people who practice this, who've been practicing it for 30, 40, 50, 60 years, and they do not have occupational disability of their hand, elbow, and shoulder, which is directly related to the healing work that they do. Okay? And that's a criticism of many other healing methodologies Because in my opinion, any healing methodology that predictably will lead to a disability in the therapist at some point in time is flawed. Is flawed. There's something wrong with it. You know? And whether you say it's a biomechanical issue, but most commonly I think it's just a repetitive stress issue. By always emphasizing the hands as your primary tool to bring pressure to the client, then you have built into the situation the possibility of disability. It's built in. It's part of the deal. Okay. And so over the past many years, you know, I've been practicing now full time since 1983. Okay. In the past, it used to surprise me how many therapists came to me as clients that had issues with shoulder, elbow, and wrist or hand. Things like carpal tunnel, tennis elbow, rotator cuff, and shoulder injuries, that their primary reason for having those disabilities was the fact that they were a healer and a therapist. And that was their primary modality. And after a while, I just stopped being surprised. And now I just assume that if you've been practicing a hands-on modality of therapy or healing for more than 5 years, you probably have already some issues that have to do with repetitive stress, deterioration, types of syndromes, whatever that might be. Okay? And so if I'm working on you, and I know that about you, when I get to the hands and arms, of course, I very specifically emphasize it. Okay? And I'm going to show you at least one variation here that's not in the book and that's not on the list. So just be prepared for that because you're going to love it when you see it. Okay? First thing is, I'm going to work the arm in 4 positions. So the first position is I adduct the arm out here at 90 degrees. All right? And it's palm up. All right? And the first thing I'm going to do is I'm going to palm press on the shoulder and on the wrist, not on the hand. Now, when I say on the shoulder, I mean as if I drop my hand straight down from the ceiling, right down onto the top of the shoulder as if it was placing my hand on a ball. Okay, that's where I want it. Okay, and then as far as the hand, there's a little trick we're going to do here. Okay, as far as the positioning. So if I fold his hand like this, if I fold the 2 sides of his hand together, you see that line down the middle very clearly. All right, especially what that is, you know, you could say that's the radial arch or that's the carpal notch or what have you. But I have one on my hand too, right? So if I fold my hand, see, I've got that notch at the base of my palm also. Okay, so when I put pressure, I cross that line on the client with mine. Okay, and that does something really interesting. All right, so now I'm up and I have one hand on the shoulder and one hand on the palm, and I'm just going to, there's a wind gate here and there's a wind gate here, and so I'm just going to rock on and press and hold for 10 count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And when I release to the surface, I should feel the same spike of heat or warmth increase that I felt when I did open the wind in the upper thigh. Because they're wind gates, and when you press and hold a wind gate, when you release, you should feel some heat. Okay, that's the energy being released from the point. But now here's a really interesting thing. About half the time when I do this, and I put all my body weight here, see, I come all the way up because I'm following that rule that we have. Really, it's more of a principle than a rule. But the principle is when the line or point is on top of the body part, relatively speaking, then my body position is over it as much as possible. That gives me maximum leverage with minimum effort. And then I just sink into it. So I'm just basically hanging out while I count to 10. But what happens though is this creates essentially a saddle joint. In other words, the base of my carpal bones squaring to the base of his carpal bones. And when I just simply apply static pressure, I push those bones apart. Okay? Now, if he didn't have this, but if he did, if he already had some good advanced repetitive stress disorder and either pericarpal tunnel syndrome or he has carpal tunnel syndromes, one of the physiologic aspects of that overuse syndrome, that's from using your thumb too much and squeezing too much to create pressure, that's what causes it, is the ends of these bones become inflamed, and the muscles like the thenar eminence here and whatnot are hypertrophied, which means overdeveloped, and they actually pull that joint together, and it causes compression on the radial and ulnar nerve and all the venous and arterial blood circulation going into the hand, and that's actually what the genesis of what causes the pain. All right, but about half of the time when I go to put pressure like this on the hand, I will actually feel the bones reduce. I'll actually feel the joint reduce. Now, in common layman's language, when you use the word reduce, you usually mean something gets smaller, right? Something gets smaller. But in orthopedic terms, it's exactly the opposite. Okay? So when we say that the subluxation, the osseous subluxation, in other words, the bones are not in the correct place, and then I do a technique that reduces that, what I'm doing is I'm reducing the deviation. I'm reducing the deviation from nominal. Okay? So I'm not actually making the opening smaller by reducing it. I'm technically making it larger because I'm pushing those bones more correctly back into where they should be seated on the wrist, where because of spasm and contraction and overuse, they come out, which means they come in a little bit and they compress those nerves there. And you'll know it when you feel it, because you'll rock on to do this press right here on the wrist and it'll go you'll feel the click, you might even hear it. Okay? And that person literally right then, as of that moment, will have less pain. Because why? There's now more circulation. Because the opening is back to nominal or closer to normal as it should be. So they have more nerve energy in the hand, and they have more blood circulation. They have more, remember the circulation terminates in the fingers and makes a 180-degree about face. But it all comes through this point on the wrist. And so if this is compressed and contracted and inflamed, okay, then it affects all of the innervation and all of the blood circulation in the whole hand. And by the way, that also creates deficiencies at the elbow, right? Because even if the elbow is not obstructed, but the carpal tunnel is restricted, I have restricted venous return circulation. So that means all the way back to the shoulder, there's actually a deficit. All right. So by opening the hands, we actually improve circulation to the elbow and we improve circulation to the shoulder. And then that brings us to a Thai principle of practice emphasis, which is called proximal and distal. Proximal and distal therapeutic emphasis. Proximal and distal therapeutic emphasis. All right, so for example, let's say my client's issue is a strain issue or a trauma-based issue of inflammation in the elbow, and we might call that tennis elbow. Okay, it might be called tennis elbow, and you've got inflammation and you've got sensitivity. The elbow might even be swollen, and you have pain when you extend the elbow or when you try and compress it. Okay, either way, it can go either way. I will work the joints that are above the elbow, and I will work the joints that are below the elbow vigorously. So a lot of therapies, if you came to the therapist or the orthopedic doctor with this elbow issue, they're going to look at your elbow like under a microscope. You might even x-ray, might even MRI your elbow, and then the therapy is going to be centric or focused on the elbow. All right, but in yoga therapy, we acknowledge that there might be an issue with the joint here or immediately around the joint with the connective tissue, et cetera, around it. However, our treatment emphasis is going to be on the shoulder and on the hand. Now, proximal means work as close to the problem as you can get without making it worse. I mean, literally, geographically. Work everything above and below the injured or the pathologic or the imbalanced area of the body. Work as close or as tight to it as you can possibly get without making it worse. All right? But, for example, if your elbow is too inflamed or too painful for me to work directly in here and work the points around the elbow directly or in the elbow directly, I don't worry about it. I go to the shoulder and I go to the wrist. Why? Because all of the energy, both energy like prana, chi, okay, comes from somewhere to get to the elbow and goes through the elbow to somewhere and then returns. So by working on the hand, wrist and hand, for example, I actually increase the circulation of energy to the elbow. By working on the shoulder and around the shoulder girdle, I actually increase the circulation to the elbow. Okay, that's proximal. Work as close as you can to the affected area without making it worse. And because we have a joint-specific emphasis, because that's how marmas are divided up in the body, it's from joint to joint, okay? Usually that means you go to the joint that's above or the joint that's below the affected area. That's where your primary emphasis is going to be. And then secondary to that are the lines feeding into it and the lines feeding out of it. And so I'll work those lines, the lines that go to the affected area. Now, if the affected area is the wrist, okay, my only choice for near and proximal is the forearm and the elbow and the shoulder. So I'd almost have the same process for a wrist problem, except that I'd have more emphasis around the elbow because that's the nearest joint to the wrist. And if I have a shoulder problem, okay, and you say, what are the joints above and below the shoulder? Well, below, meaning moving away from the center of the body, well, that would be the arm, the elbow and wrist, okay, to draw circulation from the shoulder and to improve circulation into the shoulder. But what is the other side of that equation, okay? And so, well, what skeletal parts of the body are relating to the shoulder other than the humerus? Well, it's, if you know, what? Take a guess. Give me an idea.
Deltoid? Head?
No, bony.
Oh, sorry.
Well, clavicle. How about that? And no one ever thinks to work around the clavicle for a shoulder injury. And yet, the clavicle is transmitting energy deep into the shoulder at all times. And it is a functional stabilizer to the shoulder. So the clavicle is important. And so we work points along, above, and below the clavicle. And we stretch and flex the clavicle itself. Okay? And you could even say, if I wanted to do this thing where I went even 2 joints in the sequence on the front of the body, then I would work the points along the clavicle, and then I would work the points adjacent to the manubrium and the sternum. Okay? Because here's something interesting. If the clavicle is not seated well in the manubrium, because see, you can have a subluxation or a slight dislocation in the clavicle, just like you can in every other bone in the body. Just like. And in fact, many, many times, I'll put pressure on the head of the clavicle next to the sternum, or manubrium actually, because this sternum is really 3 bones, not 1, okay? We talk about it like it's 1, but it's really not 1, you know? When I put pressure here, you'd be surprised how many times I get a reduction. You'd be surprised. Especially with people who have chronic shoulder problems. You see? All right, and then if I was going to say on the back side, okay, what would I be looking at?
Scapula.
Scapula. So I'll work. So even though the injury might be interior to the joint of the shoulder, or the inflammation, guess what? Following the principle of distal and proximal, okay, I will work completely around the scapula. I'll work the superior border of the scapula. I'll work the medial border of the scapula. I'll work on all the energy lines that radiate like fingers on the back of the scapula through the soft tissue that is actually anchored to the scapula. Okay? And I'll work completely around, and I'll articulate the scapula postures, for example. Even emphasizing in spinal rotation, for example, because when we do spinal rotation and I push down on the shoulder, I'm actually adducting the scapula toward the spine at the same time. Although you can't see it, but if I was doing this on a glass table, even though it looks like I'm doing a spinal rotation in the supine position, when I push down and stretch into the shoulder here, if I was on a glass table and you were looking up from the bottom, you'd see the scapula, the shoulder blade would rotate in. Okay? And so you'd see that there's an emphasis, even though I'm pushing on the shoulder, that I'm actually mobilizing the scapula. And in a spinal rotation. All right? And then distal means find something as far away from the problem as you can and still relate to it. And treat that. In other words, find something that, and I mean, when I mean far, I mean like reflexology of the shoulder and arm points on the foot. That's far away. That's as distantly as you can get philosophically and find a relationship to the issue. Okay? I would work the reflex points on the feet. But also more distantly would be anything that articulates the spine. And so it's very, very common, for example, with people who have wrist, elbow, and shoulder problems, if you flip them over and you look at the back, you're going to find adhesions, lesions. You're going to find vertebrae that are subtly or grossly out of alignment between the shoulders, and especially on the same side as the chronic injury is located. And so that means my distal, technically speaking, is going to be a spinal rotation, or it's going to be some compressive postures that will, like bow poses, camel poses, downward facing dog, and postures that actually create motion in the vertebrae between the shoulder blades. Okay? And that's pretty distant. That's pretty distant. Okay? All right, so now let's go back to the 4 positions on the arm. All right, so 1, I started out with palm press and hold for 10. And then there's this technique, I've mentioned this before, this little ditty. Both hands press, top hand travels. So top hand is the hand that's closest to the head or toward the center of the body, okay, in this position. But I'm still pressing on the bottom hand. Both hands press, top hand travels. And I'm going to use a technique which is called rock on. So when my seat is back, there's no pressure. When my seat is forward, and I let my belly drop, let my back collapse, because I really want my weight to go into this. I'm not curving my back up like a cat. I'm collapsing my back so that my belly sort of distends to lower my center of gravity into my hands. So I rock on and press. Skip over the joint, because that's another principle that we're trying to avoid direct pressure on the joint unless we're doing it on purpose, okay? And continue the palm press all the way to the wrist. So simple, right? But compression especially broad, deep compression. I want to talk about that just for a second. Okay, broad is the width of my hand is big and is not very precise, especially when I'm palm pressing on the arm. Okay, now we've got all of this musculature, we've got all of the innervation, we've got all of the vascularization, blood supply, we've got the interstitial circulation, interstitial fluids and so on that are in this whole circuit here. Okay, when I use broad, deep, non-specific compression, okay, what happens is I am also forcing the soft tissue against the bone within it. All right, so just follow me, visualize for a second. When I compress the arm here, okay, I'm smushing, technical term. One of my scientists said mushing. You know, I'm like, I don't care, mush, smush. You could be scientific and say it's a palmar compression, okay, but it's non-specific, which means I'm covering a mad bunch of tissue here, and I'm squashing it, but the bone is in there, right? So the soft tissue and everything else, including the nerves, veins, arteries, and so on, distorts around the bone. Do you understand? Mm-hmm. Distorts around the bone. Now, soft tissue, muscle, connective tissue, etc., all follow predictable patterns. In other words, like the bicep, the coracobrachialis here, the triceps, etc., the muscle fibers run in the same line as the arm. They run along the length of the muscle. Can you picture that? Okay? But when I compress them, they go in every direction away from each other. And then the humerus is here, for example, and the muscle and connective tissue will wrap around the bone and will distort laterally. All right, do you see, can you visualize that? So as I compress the muscle here, the tissue wraps around the bone and distorts laterally. In other words, I'm not stretching it along the length of it, although there is some distortion along the length of it. But there's also a huge amount of distortion that goes lateral. It's actually transverse to the normal direction that the fascia and connective tissue, the soft tissue of the muscle, and so on is going. Now, what that means is that's called, I call it literally a explosive decompression, because you have all of these little micro tears and microscopic injuries and scar tissue from old injuries and so on and so forth that you cannot isolate. You cannot isolate. You can't feel them in most cases unless they're just huge. Okay, you can't feel them, but they're there because the muscles have thousands and thousands of layers of bundles of fiber. Okay, and you can't feel the scar tissue and adhesions, the lesions where these bundles have been injured in the past and they're adhering to each other, and the damage to the intermuscular fascia and connective tissue due to chronic inflammation and or atrophy from lack of use. And when I do a deep, broad, deep, non-specific compression, I am breaking that apart in every direction, every which way. Okay? And on one level, you'd have to say that I'm even to the point of creating little microscopic injuries. Okay? However, here's the thing. As the structure responds to the therapy, and over a few days, as those little micro tears that are breaking across the adhesions and the fascial lesions, and for those of you who don't know, that sounds like I'm speaking Greek entirely or Latin entirely. A fascial adhesion is when you have like a muscle like the bicep, and under it is the coracobrachialis. Each of those muscles is wrapped in its own fascial sheath, independent of the other, which is supposed to allow the muscles to slide independently, to move independently of each other, depending on the range of motion. When you have injury, when you have inflammation process, when you have atrophy, little adhesions occur between those tissues like Velcro, locking them together and preventing them from functioning independently like they should. And also these lesions, these little scar filaments, because they're collagen fiber, so it's the same material in the body as every other scar in the body, okay, also impede circulation. And especially they impede the interstitial circulation. In other words, there's supposed to be fluid circulating between these muscles as well. And I'm not just talking about blood, okay, the interstitial fluid, lymphatic fluid, okay, it's part of the inhibition which occurs from chronic inflammation, for example. And it's also why you get tight and sore and it hurts when you try to stretch, is because when you try to move, these little Velcros, which are actually a disease process or a trauma process, because as they tear loose, they don't want to let go. And so you'll have pain and you'll have a limitation on your range of motion. Okay? The best way to break up all this fascial adhesion between these tissues and to open it up for circulation is broad, deep, non-specific compression. Where everybody else wants to get in there and strip out the fascial lesions, that they actually believe that they can do this. Okay? It's done in, I won't name any disciplines because I don't want to talk smack about anybody, but it's the most common thing in the world, usually under a heading of some form of so-called deep tissue, where you're supposed to get in with your thumb or with an elbow or something, and you're supposed to strip along the fascial plane to break that apart, okay? Even if that was possible, and I'm not saying some of it's not possible or all of it's not possible, but even if it was possible to do that, the maximum amount of tissue that you would be able to exert enough force against externally to break apart a scar that's on a fascial plane would be very small. It might only be like 2-3%. In other words, you can only affect what you can touch. All right, what you can actually get to. And since the body is absolutely perfect at distributing impact from the surface as a protective mechanism, in other words, when I put pressure on one point on the body does everything that it can to distribute that energy over the widest possible surface to prevent me from creating an injury. All right? But when I use broad, deep, non-specific compression, okay, it short circuits that process. It can't actually distribute that energy effectively. And then if I compound that with my partner in creating this pulling apart of the fascia and connective tissue is actually the skeleton that's within the soft tissue, because I'm leveraging against the skeleton and it's acting like this. So I go to push, here's the bone, I push the soft tissue down and look what happens. The soft tissue wraps. In other words, the bone doesn't distort at the same rate that the soft tissue distorts. The bone will flex, and that's a good thing, okay? But it won't distort at the same rate as the muscles and connective tissue on top of it. So what happens is the more pressure I use over a broad area, then that tissue wraps and collapses around the bone, which is a lateral decompression, which means that I'm actually bringing energy directly to tissue that I could never in a million years get to with my thumb. Never. If I pushed hard enough to even begin to get to those deep layers, like let's say the fascial boundary between the bicep and the coracobrachialis here, if I pushed with my thumb hard enough to strip the whole length of the fascia that they share as a border, okay, you would be bruised for weeks. You would be bruised for weeks. And I still wouldn't be able to get more than a percentage of it. And so there are people who believe that that's an effective way to do things. Well, our tradition says, yeah, it's kind of elementary, and it doesn't make any sense. And besides, we can do this easily, and we can get to the deep tissue that you could never touch with your thumb, no matter how strong you are. And again, part of the genesis of the carpal tunnel and the deterioration of using the hand in therapy is because you're trying to push hard enough to get to the deeper tissue. And in traditional yoga therapy, we say, well, forget that. Use broad, deep, non-specific compression, and use the bone, which is in the skeletal segment that's in the middle of that tissue, as your wedge to break apart the lesions. Isn't that cool? I just, when I think about it, I'm just like, wow, that is so cool. And then when you do it, and you find you're no longer straining, and you're getting this amazing result as far as almost instantaneous reductions in inflammation. I've had clients who in their inflamed arm, like a mastectomy client, post-mastectomy, with edema in the arm, okay? That edema at the end of one session was reduced 20 or 30% in one session. By the end of the session, it was actually measurable. If I measured it before I did the treatment, and then I do the treatment, and then I measure it again, 20-30%, even in one treatment. And yes, the brilliant part, it persists. In other words, it doesn't just come back the next day. And in fact, we've seen edema reduced in one session that didn't appear to return for months. For months, even from one session.